right, so y'all know already, you have a lot of stuff on this exam. It's all about perfusion. Literally everything's about perfusion for the most part. Chapter 31 was all the ECG stuff, so go back and review that lecture if you haven't already, or that enrichment session. But what I do, and this is what I suggest you do, I pull up the syllabus and I copy and paste straight from the syllabus, and I click right here on 32 and I add a note and I put exactly what it is that the syllabus tells me I need to know right here. Why? Because I don't have to waste my time studying stuff that don't matter. If it's not on that page, I should know it from 242. So it's not going to be on my exam per se, but what do we do with that? So that's kind of where I start. I know what I want to go through. So my recommendation always for each chapter is really look at the priority. The priority is perfusion. We're talking about getting oxygenated blood to the end user. Everything about cardiac boils down to one concept, and this cardiac output. Cardiac output is just your heart rate times your stroke volume. And we're going to look at that because everything we're going to talk about, every disease of the heart, every condition of the heart leads back to one thing, and it's just heart failure. So I love to ask the question to you, what does the term heart failure mean? What is that exciting you? Somebody tell me what heart failure means to them.
It means when the heart cannot function as it should.
Yeah, basically the heart failed to do its job, correct? And the only job of the heart is to pump enough oxygenated blood and nutrients to meet the demands of the body. The second it can't do that because the heart rate is too low or the stroke volume is decreased, that is called decreased cardiac output. That's just heart failure. So heart failure is not a disease in itself. It is a byproduct of heart disease that caused the heart to fail. Myocardial infarction causes heart failure. Infective endocarditis leads to heart failure. A valvular problem leads to heart failure. All paths lead to heart failure. So why do I say that? Because eventually every sign and symptom looks exactly the same. Left-sided, right-sided, they all kind of come back and make the other side fail. But for your exams and for understanding, we do differentiate left and right heart failure just to say certain diseases have an impact on the right side. So initially you will see right-sided heart failure based on this disease. Initially, with this disease process, you will see signs and symptoms of left-sided heart failure. So the only reason anybody cares about left-sided heart failure versus right-sided heart failure is so it can help you identify a causative agent. Because eventually, regardless what the causative agent is, it all leads to heart failure, left and right. So I just want you to have that concept. So as we move forward, let's think about left and right side of heart failure. It's going to be imperative that you know the difference. So I just highlighted that for a second for myself. I'm not going to keep looking at it. If I scroll down, I'll keep talking to myself, right? So the concepts of heart failure is just that. If you know the way that the blood comes into the heart, deoxygenated blood returns to the heart via the superior inferior vena cava. They go into that right atrium. They go through that tricuspid valve. They go into the right ventricle. And then that right ventricle squeezes blood that has no oxygen in it out the pulmonic valve into the lungs where you get gas exchange. Then it all returns right back into the heart through that right atrium, the left atrium, through the mitral valve into the left ventricle, and then it gets squeezed out of the aortic valve to the circulation. So when the left side fails, it backs up into the lungs. Everything looks lung related. If the right side fails, it goes right back into systemic circulation. So everything is like peripheral edema. So we're going to look at some of the diseases so you can determine how the presenting signs and symptoms really indicate what kind of disease process you're looking for. Why is that important? Because y'all got a test coming up. Let's just be honest. So, does somebody pop in? Y'all keep me posted if anybody shows up, okay? All right. So that's just where we're at. Like I said, I'm not trying to reteach everything because y'all have a teacher. I just want to let you know what my thought process is here. I look at a few things as I go down. I look at this New York Heart Association functional classification system. I know this shows up later on in life as well. Maybe not this test, maybe not exam 2 or 3, but eventually it shows up. This is just one of those things I want you to think about. When you have heart failure, how do you fix a broken heart? And that sounds funny. I'm not meaning it to be like you're in love, but how do you fix a broken heart or a heart that failed? What can you do? I like to ask questions.
Get a new one.
Yeah, I like that, Faith. If your heart is totally broken, get a new heart. So that transplant list, that's what we're talking about down here. So we have to think about people who have heart disease as being somebody in need of a transplant eventually. I mean, it's just, it could be possible. So just, it's something to think about. Listen to the terminology, know that it exists because you never know where it's going to pop up. That's all. I just want you to associate that word with something later on. All right, so magic. This is magic to Mr. Streb. I mean this every time I teach a class. If you get this concept that cardiac output, all cardiac output is your heart function. I look at cardiac output as your heart. What's the point in having a heart if it doesn't have cardiac output? It's just a waste of space. So everything I need to know about cardiac is right here in this simple mathematical equation. Cardiac output, the product of the heart rate and the stroke volume. Therefore, anything that drives the heart rate down causes cardiac output to go down. Anything that causes the stroke volume to go down causes cardiac output to go down, which all leads to heart failure. So every disease in some level will either impact the heart rate, the stroke volume, or both together. That's all we're looking at. And we are trying to treat the signs and symptoms to increase the heart rate or increase the stroke volume. That is a nurse's job. All right. So if you need more patho, go back and look at the patho, go back and look at renin and angiotensin 1 and 2 and how, sodium and water control blood pressure. That was a 242 function. Definitely go back and understand that. Your B type, so your peptide, your BMP, this is a gold standard pretty much that we use for heart failure diagnosis in America. When you go into a hospital and we're trying to see if you have heart failure, not a myocardial infarction or a heart attack. I said heart failure is totally different, right? Because a myocardial infarction is a death of the myocardial tissue, which will ultimately lead to what? Heart failure, because the heart will fail to do its job if the muscle is dead. So the BMP is the gold standard for your heart failure diagnosis. Typically it's greater than 100, the actual BMP. So it doesn't say it in the book per se, but it's something I know. Why does that happen? It causes this stretch in that left ventricle, and that stretch in the left ventricle releases this peptide, and it lets us know that it's been stretched out beyond like it should. And that's how we know we have heart failure. It's kind of a cool thought. So if you ever see a test question, or if you're ever on a clinical, or if you're ever with a patient, you see that BMP and it's elevated above 100, you can be like, ooh, you probably got heart failure. It's a good thing to know. As you can see, I'm not going to go everything over in the book. It's not my intention here. Is to highlight things that I know that are important that help you kind of understand the concepts better, and there are things that you might have overlooked as you were going through your own reading. So let's just go back to heart failure. We're going to be required to know the signs and symptoms. You are going to have test questions ultimately to ask you about signs and symptoms, because every question is about the assessment data and the nursing intervention. So we're going to have to know some of the causes of left-sided heart failure, how it presents, and what we can do about it. Definitive things, really, because that's what NCLEX wants you to be able to do. Identify when a patient laying in your bed is having an issue and what you can do to make sure they don't die. Because we don't diagnose, we don't treat. We look at nursing diagnoses and we fix signs and symptoms to the best of our ability. So let's move on from there. A couple of things I want you to understand. With left-sided heart failure, the majority of your signs and symptoms are going to be what? Pulmonary related. There's a picture in the book. When I get to it, there's a picture of a heart and the valves, or maybe I Googled it later. That's not in the book. I Googled it. But you know what? This was last night when I was studying. I studied for this before I show up, because what kind of teacher would I be if I didn't do my pre-work before I showed up to you, right? But here's a concept that really just, I've known this forever, but it kind of messed my mind up. Is, you know how we have valves to keep blood from regurgitating back into another chamber in the heart, right? We have a mitral valve, we have a pulmonic valve, an aortic valve, we have a tricuspid valve. They prevent backflow. There is no valve that prevents blood from the right atrium going back out into systemic circulation. There's no valve to prevent that blood in the left atrium from going back into the lungs. Not that we talk about, right? So it's an easy open shot. When that left side of the heart fails to pump the blood out, it all backs up into your lungs. That's why left-sided heart failure looks like everything in your lungs. I mean, literally, you can take your highlight and you just highlight stuff. I can't do it all for you, but you have to have that understanding that coughing, not being able to sleep, any signs and symptoms of hypoxia, that's all related to heart failure, especially left-sided heart failure, because the fluid now starts filling the alveoli spaces and you don't get gas exchange. You're effectively drowning. That's all left-sided heart failure is. So a big thing we talk about as heart failure becomes more severe, we start experiencing something called frothy pink tinged sputum. Your book also says blood tinged sputum. But what is pulmonary edema? What is that? What is pulmonary edema, y'all?
When there is like excess amounts of fluid in the lungs.
Yeah, absolutely. Thank you very much. So
And
to
breathing
me,
is compromised. So priority is breathing.
absolutely. Absolutely. Left side of heart failure, your priority is to do what you can do. If you can give extra medication to make the heart rate faster or the stroke volume stronger, great. But on the same vein, the patient can't breathe now. So now part of your thing is exactly that, is pulmonary function at this point. So I need you to be aware that pulmonary edema is a byproduct of left-sided heart failure. Now, those pulmonary, they're not hand in hand, but it is. When you see pulmonary edema, you have to think left-sided heart failure, because the left-sided heart failure backs up into the lungs. And that this is always the same thing, that frothy pink tinged sputum is always associated with pulmonary edema. Is it still left-sided heart failure? Are you going to be able to tell the difference later on? Probably not. But understanding these little nuances is how you on a test are going to determine what the cause is or what you're looking for. So yeah, and your patients will come up with this paroxysmal nocturnal dyspnea. I've seen this on ATI and NCLEX before, so I bring it up because it would be bad not. This is where people feel breathless after they fall asleep. Because why? What happens when you fall asleep? You lay flat, and now the fluid starts to fill your lungs, and now more of your lung spaces and more of your alveoli are filled with fluid, and now you truly are dyspnic because of the way you're laying. So just things, go back and look at this. Pulmonary edema caused by left-sided ventricle. I even do it twice because I've seen it so many times. Key features just means signs and symptoms. Go back and look at it. If it confuses you and you don't understand any of why this is happening, go back to the cause of it. It's all related to hypoxia. Every time you don't get good gas exchange, you're tired, you're weak. All of these things matter. Why do you have oliguria at night? Because as I lay down and I have fluid volume overload, it starts to get my lymphatic system. I start to drain all this fluid out and I have to pee more. That's why I have to pee more at night. It should start making sense. You don't have to memorize anything. In 265, memorization should be over at this point. 242 is a lot of memorization. 265 has to be concepts. You have to understand why the signs and symptoms are there, because if you don't, all you're going to be doing is memorizing every test. At this point, I want you to walk into a patient's room and say, you have left ventricular failure. I know why you're confused. I know why you're dizzy. I know why you're tachycardic. You need to know the why. Same thing with right-sided. You need to understand what dependent edema is. What dependent, I put it over here, gravity dependent, meaning when you're sitting still and you have lots of fluid, you have right-sided heart failure. Basically, you have some venous insufficiency. Not really, but it's the same kind of outlook. You can't take that systemic blood that is deoxygenated and return it back to the heart because the right side has failed and it's pushing pressure back. So all of these should make sense. That's all I'm trying to get you to do. As you lay down, fluid returns to circulation. This is what happens. Polyuria at night. Say oliguria at night, right? So nocturia at night. There's all kinds of things going on. It's interesting to think about the concepts, and that's where you have to be. Like I said, I'm just going to go through. I've taken notes already of things I want to talk to you about because it's just important. This is not anything on your exam per se, but I just like to think about what is your job. I think it was Rickson where Rickson was saying earlier about, or was it Devin? I forget who was talking earlier. I apologize.
Yeah, it was me, Rickson.
Okay. I see a tiger and I'm like, I thought I saw a tiger, but I don't want to, but yeah, that's what it is. And when I start thinking about what it is we do with a patient in heart failure, we support whatever the signs and symptoms tell you. Here's something I want you to know fully well. As a nurse, I don't care about the physician. I don't. The physician does one thing for Louis Streb. You diagnose the patient with a diagnosis and you give me orders that you want me to do for that patient. That's all I need from the doctor. Everything else, I'm a nurse. Nobody tells Louis Streb how to be a nurse but Louis Streb, because nobody else is a nurse but Louis Streb. I don't need anybody else's help. So when my patient's laying in bed, I know what the doctor has ordered and I do that. But I look and think, what is my job? Is to maintain an O2 saturation above 90. Is to really think about when they're dyspneic, what can I do? High Fowler's position. There are things I can do. Y'all, NCLEX focuses on the things that you can do because NCLEX is written by nurses for nurses to make sure you can be a nurse and not a physician. So anything nurse related, you have to understand. Anything doctor related, you at least have to understand what they should be ordering. So when they don't, you can advocate for your patient and say, no, ma'am, no, sir. Best practice to say you should be giving this medication due to blah, blah, blah. Know your worth. Y'all are bad. Y'all are awesome. I almost said a bad word. Y'all are pretty cool. You're going to be graduating soon. You're going to be registered nurses. You're going to be leaders in this profession. You're going to have to tell people yes and no because you are the only nurse on that floor at that moment with that patient. So Understand what your job is. I just put that in there because I really want you to understand it. Know that every one of these patients, I don't care about the diagnosis. I'm going to go back to the top again. I don't care about the diagnosis of heart failure. I don't treat heart failure. Never in my entire life as a nurse will I ever treat heart failure. That is the doctor's job, or the physician, the nurse practitioner, the PA. What do you associate heart failure with? What nursing diagnosis comes to mind when you think about heart failure? You are in 265. You graduate in like a couple months, really.
Impaired gas exchange.
Impaired gas exchange, absolutely. So I'm thinking impaired gas exchange. I'm thinking Mr. Strip saying why? What is the why for the impaired gas exchange? What other nursing diagnoses affects my impaired gas exchange with heart failure?
Could be arteriosclerosis.
That would be, it's not a bad thought, but that would be a medical diagnosis. I'm only talking about nursing diagnosis because
Decreased cardiac output.
Decreased cardiac output, sure, caused by heart rate, stroke volume. What is the main thing though? What does everybody with heart failure, left side of heart failure, end up with? Fluid volume overload. Let's just be honest. If you have fluid in your lungs, are you not overfilled? Are you not overfilled with fluid?
Mm-hmm.
It is. It's one of the diagnoses. If you were to do a concept map, you'd have about 6 different things going on here. What I need you to understand with left side of heart failure is it is just fluid volume overload, y'all. You have too much fluid built up into your lungs. We have to think about diuretics, loop, potassium wasting, potassium sparing. We have to think about all of this. All of these things become problematic. We start talking about T waves, right? And ST elevations and ST depressions. We start thinking about hyper and hypokalemia. All of this matters, y'all. You have a patient in heart failure, and you're going to give diuretics, and we already are worried about other stuff because we know that hypertension is caused by that renal stenosis, and we already know that they probably have some kidney failure as well. So yeah, when you get to heart failure, you probably have kidney failure as well, and we also know that you're going to have hyperkalemia. Like that's what nurses do. This is what makes nursing so hard. And if you just step back and you quit worrying about the medical diagnosis, you start realizing that everything leads to the things you can worry about. I can do stuff about fluid volume overload. I can't do anything about your heart failing. The doctor can, but I can treat the signs and symptoms associated with the fluid volume overload secondary to the heart failure. That's why concept maps matter. Don't ever look at a concept map and get mad again and be like, I hate this. Then you don't, I like to learn. Take it as a learning opportunity. Mr. Streb has done so many concept maps sitting in this bedroom to prepare to talk to you all because it's that important. You need to know how they interact because look at the test you have coming up. I assure you, cardiac, renal, liver, all that is related. This is all a perfusion problem. Your spleen, that's all part of perfusion. If you look at the body as a whole, the heart beats, it shoots oxygenated blood out of the left ventricle. It goes to the spleen, and the spleen filters that oxygenated blood, and then it goes back eventually to the kidney where it filters the deoxygenated blood where it returns back to the heart. So it's all one big old closed loop. Blood pressure anywhere affects both of those organs. So once you get this concept down, you don't have to memorize, you can just understand. And that's what I hope you do eventually. You're not going to get it right now, but that's my hope for you by the end of this term. If you keep coming to these, maybe we can get somewhere. All right. So how do we prevent things? How do we manage pulmonary edema? So go back to what pulmonary edema is. This is just one of the things your book says you have to know. So pulmonary edema, to me, is just third spacing. You have too much pressure in the pulmonary vascular system. It causes that pressure to build. That third spacing, the intervascular fluid now seeps out into the interstitial in the lungs. That's just your alveolar spaces. If you can't get gas exchange, every sign and symptom makes sense, right? If I can't get gas exchange because there's fluid in my lungs, it's going to sound like crackles. If I have fluid in my lungs, it don't matter if I'm running, walking, or sitting on the couch, I'm going to have a hard time breathing because fluid does not allow air to pass through it. If you don't believe me, put your face in the bathtub and try to breathe. Don't do that. Please don't do that. But if you've ever tried to breathe underwater, you know what I'm talking about. That's what I'm saying. Coughing with frothy pink sputum, that is just a sign and symptom. If you don't understand it, go back and look at it. These are things that are going to pop up. These are things that will show up in the stem of the question. Let's say your patient is crackles, dyspnea at rest. They have a cough with frothy blood-tinged sputum. Oh, I'm not going to tell you they have left-sided heart failure. You got to know they have left-sided heart failure, and you got to know that left-sided heart failure causes pulmonary edema because it backs up into that's the test questions, y'all. No one's going to give you anything easier than that. So if you know what is causing the problem, you don't ever have to memorize anything ever again. You have to commit it to memory at some point. All right, let's keep going through there. Like I said, I'm not going to talk about anything that I don't want to talk about right now because there's no point. Let's get into our heart valve diseases, right? So what do heart valves do? Mr. Streb already told you, heart valves prevent that backflow of blood into the chamber it just came from. So if we think about how the heart works, the left atrium is right here where all the deoxygenated blood enters the heart. Your SA node fires, it sends out all of that electrical activity to the atriums and it causes depolarization of the atrium. You know, your SA node fires, it's a P wave, causes the atrium to depolarize or squeeze, and it shoots all the blood from the atrium through those valves, either through the tricuspid or the mitral valve, into the ventricles. As the SA node fires, the AV node slows down the conduction, letting the ventricles fill, and then it causes depolarization of the ventricle at your QRS complex. Why do I tell you this? Because those valves prevent the blood in the ventricles from going back into the atrium. It prevents the blood in the lungs from going back into the ventricle and from the body back into, like, there's valves. When those valves don't work, they allow the blood flow to come back in. Blood flow backs up. If you've ever had a clogged pipe in your toilet and you flush the toilet, all the poop and everything comes out. That's all we're talking about. When the valve doesn't work, it backs up. So why is that problematic? I'll tell you why it's problematic, because if I don't have good preload and afterload, I don't have good stroke volume. Cardiac output equals heart rate times stroke volume. If my stroke volume is down, I am in heart failure. That's it. So mitral stenosis, mitral regurgitation, mitral valve prolapse, aortic stenosis, they all lead to the same thing. All roads lead to Eden, right? They all lead to heart failure when you talk about the heart. So if you can think about that, they all look the same at first. But why do we differentiate? Because if we think about mitral stenosis, we think about what the causes are. The causes of mitral stenosis are rheumatic fever. If you don't understand that rheumatic fever is due to group A streptococcus, I just put gas because I'm too lazy. Group A streptococcus, people who have strep throat over and over and it goes untreated, and then they go to the dentist and they don't take antibiotics before pre-dental work, and then that group A strep gets into the heart and it causes rheumatic carditis, which causes the mitral valve to become stenotic and hard. And when it doesn't open and close like it should, it allows blood to go in and out and you don't get good cardiac output. That's nursing, y'all. That's what I learned from nursing. That's what I learned about mitral stenosis, because you have to know that. Why? Because if your patient's laying in bed and they have strep and then they start having signs and say, you have to paint the picture. The doctor's not there. The hospital was designed for doctors to write orders for nurses to do stuff, because nurses are valuable. If you're not going to do your job in the hospital, you don't deserve to be a nurse, and you should probably work somewhere else. I mean that with all due respect, love, and dignity, because my children go to hospitals and your children go to hospitals. I mean what I say, y'all. So understand what mitral stenosis is. Understand what it causes is basically heart failure. So the signs and symptoms look the same. Know the little stuff so you can, that's what the test question cares about. That's what NCLEX cares about. You're never going to know if they have mitral stenosis. You're not, because the doctor's going to have to do it, an echo, and they're going to do all this stuff. When you're laying in bed, you just know that something's wrong with them. If your patient has this diagnosis, you need to be looking for certain things. That's what we're talking about. So go back and look at some of this stuff. I can't go over all of it with you. One is an insufficiency, one is a prolapse, one is hardening. The same thing with your aortic stenosis. Think about where these valves are, where they back up into. It will start giving you an idea of what right-sided versus left-sided looks like. You need to know that anatomy and physiology and how it goes through. If you don't, I can't make you figure that out. Go back and look at it, okay? All right, so ultimately, once again, what do these lead to? Heart failure, that's all it is. We are going to talk about some of the things that how you can replace it and treat it, because I've seen those on exams in the past. ATI, NCLEX, your own, unit exams. I'm not ever going to prepare you for an exam like straight for questions, because that's not going to help you be a better nurse. I promise you the stuff you learn here will help you on your exam immensely though, okay? I promise never to waste your time. So what happens when you have a valve that goes bad? What can you do for the bad valve, y'all? You tell me what you think you can do with it.
Replace it.
That's pretty much it. So there are options. There are non-surgical heart valve options where you don't have to go in and do open heart surgery. And there are ones where you do open heart and you replace valves. As a matter of fact, my mother had this one done. It's called a TAVR. And I don't believe it's anything you have to really worry about, but it's kind of cool. They go through your whatever valve, whatever artery they decide. For my mother, they went through her femoral artery, and they put a balloon catheter up into where she had mitral valve stenosis. So they went to her mitral valve just like this. They put this balloon in there, just like you would do if somebody had a clogged artery, like when you do angiograph or angioplasty. But what they do is they put this new valve in there and they open it up and it pushes the old valve out of the way. And then they have a new valve that pushed the other one out of the way. Kind of cool. Now, my mother died later on, not for that, but it did cause some bundle branch blocks and things of that nature, but that all resolved. But what a cool idea that you can replace a valve without having to open you up. But I need you to understand, part of your job is to understand the pros and cons of each one. Why? Because you as a nurse are going to be teaching patients. Patient education is always your responsibility as a nurse. So if it talks about any kind of things like anything that the patient might need to know, that becomes more of your issue now. So I start thinking about, why do we have different types of valves? And if you look here, it talks about different types. It talks about prosthetic valves and it talks about biological, so tissue from a different animal. Do you need to know all of it? I know that biological valves, like xenograph, is one I've heard, and I've seen them use different words on different types of tests. Just do yourself the value of understanding what you're doing for a living. So biological, we're talking about from another species, typically from a pig, and they call it a porcine, and that's the kind of valve we're talking about. They're good. They're good to have around because they last for a little while. They last about 7 to 10 years. The best part is you don't need long-term anticoagulants, so you don't have to be on, some kind of low molecular weight heparin. You can just get it and it stays for 10 years, and you can live your life. Do you have to go back and get another one? Yes. So these are test questions where NCLEX might say, which of the following statements by the newly diagnosed patient would require intervention by the nurse? That's why it's important. So what's the advantage? No anticoagulation. What's the advantage of getting a mechanical one? It can last forever, but you're going to have to be on lifelong. Go ahead.
So for prosthetic, right? So from what I've learned, that it can cause, well, the patient is on anticoagulants for life, and they're also at risk for infections.
Nonstop. You are absolutely correct.
Can you explain as to why they're at risk for infections with a prosthetic valve? Is it because is more invasive, or it's just
yeah, not so much the invasiveness, but every time you lice those, you have a mechanical valve in there. Your body is constantly going to be fighting it. It is an intruder. So your body's always going to be out there. Hyperinflation, anti-inflammatory things is constantly trying to go against it. That's why you're always going to be on these different types of anticoagulants, because you are going to break down the mechanism. The mechanical part of it is going to cause lysis of red blood cells, white blood cells. It just allows any kind of, and if you go down here and look down here, it's kind of the same concept as dental work. When you have a valve replaced, it's just a place where bacteria and viruses can attach to. It gives them a source to attach and start to breed. I mean, that's really what it boils down to, I think, more than anything else. If you look here, it says patients who have a valve replacement, open heart surgery, CABG, and you can go look at that more. When you go do that, they have to think about the dental examinations. They can't have any dental problems. Why? Because we've already talked about how if you have dental bacteria in your mouth and you have any kind of procedures, or you have an open sore, or there's leaking root canals, that gets into your systemic circulation, and it's far more likely to get to your valves. And that's when we start talking about we can keep going back up here and looking, like rheumatic fever and mitral valve disease. That's kind of what happens. That's why we're worried about patients who have valve replacement. They're going to have that infective endocarditis, basically, is what we're going to end up with. Does that answer your question?
Okay, so to understand, so because they have a prosthetic in their heart valves, is going to, the body's going to keep fighting it because it's an intruder. Does it also mean that they're going to be on antibiotics along with the heparin?
So there are all kinds. Some people have, and I don't know about this specifically, so I don't want to lie to you because I'm not there, but there are people who have to be on anti-rejection drugs for certain things, or immunosuppressant type things. Not typically. When you get a valve replaced, you shouldn't have to be. It's the anticoagulation part first. What we do more importantly is to ensure that you're not getting, it's the dental work. I mean, every time you think about valve replacements, we think about dental work because that's the most likely way of getting that infection into your systemic circulation. That is the big one. There are other stuff, but like I said, the big one is right here, y'all. It's the bleeding. It's not the infection. It's not the overarching concern, unless we're worried about dental work. So I would relate the two together. Is there more to it? Absolutely. But that's where I want you to make the connection for now. And you'll build upon that. You will. When we get to infective endocarditis, it's the same thing. That's what we're talking about. anything that allows you to have a more likely chance of catching, an infection. And that's what happens when you have a valve that does not belong there. Like it or not, anything you put in your body that was not there when you were born with it is probably going to cause problems. It's just the way it works. All right, I hope that answers your question. If not, we'll come back to it when we get to infective endocarditis. I'll kind of hit it again, okay?
Mr. Strap.
Yeah.
Mr. Strap, sorry to
Please.
interrupt, but
Please.
I had a thought when we were talking about this just right now.
Please.
Is it, and please correct me if I'm wrong, because I'm trying to understand it. It's not so much that because you have the valve replacement, it makes you more at risk for infection. It's the fact that because that heart valve is not functioning at its full capacity because it's not originally yours, it's more susceptible if you get an infection from an outside source. Like it doesn't cause the infection, but you have that dental work and then the blood clot is infected and it sticks and then it starts to break off. Because that valve goes to your heart, it gets pumped everywhere throughout your body, correct? Is that what they mean by more risk for infection?
I think where you're going is right. Devin, I think where you're going is right. I think where all you're going is right. And it's basically all we're saying is if you have a heart valve replaced, it makes you more susceptible to infective endocarditis. So if you don't think about your dental work before you go in, they won't even do a valve replacement if you have dental work that is still due. It's that serious. Patients need to have all periorbital dental examinations. If dental caries or periodontal dentist is present, the problem must be resolved prior to a valve replacement. It's so problematic that they won't even do this surgery if you have cavities. That's why I'm saying it's not that it's a big infection. It's that if you have a valve replaced and you have group A strep or anything else going on in your mouth and they do dental work, that group A strep will get in there and it can cause mitral valve stenosis. We already know that. So if you already have a valve that is not working correctly and we just replaced it, when you get those bacteria, and I don't know why, I don't know the why to a lot of stuff. None of us do. And there's probably more of a why. Mr. Strep never cared about the why. I just understand if you get a valve replaced, I know you're more susceptible. I'm a nurse. That's what I care about. So that's what I'm trying to get you to understand. There's more to it, of course, but it would take forever and we'd waste time just concentrating on it. And there's no need. That's the importance right there. Does that make sense? Does that help you? Because also importantly is you need to think down here. I don't know if you know anything about an INR. An INR is like 1, therapeutic is 2 to 3 times. We're talking more than that. They need an INR of 3 to 4 because it's such problematic that it's so problematic that they could cause a blood clot that we have to do all kinds of stuff. A valve is great because you're dead without it, but a valve is not wonderful because there's so much crap that can kill you with it. I mean, it's better than being dead initially, but there's a lot you have to worry about. So those are the big things I would focus on because you can spend all day going down this rabbit hole and never understand it. It'll come to you eventually, I promise.
And to piggyback from what Devin is saying, so basically, if you're to do like a dental procedure, you should withhold the surgery at least 6 months, right?
Yeah, so there's so much stuff in there, absolutely. So just understanding that if you're on an exam and you start talking about that, you could be like, okay, I get it. I get what they're talking about now. I understand the concept of why. When you start thinking about stenosis and you start thinking about why the mitral valve failed, when you start thinking about the group A strep and you start thinking about that infection, why did we have to replace the valve in the first place? Well, if that causes the valve to fail in the first place, any valve I put in place after that could have the same problem. So think of it in that way. And then think about what you do afterwards. Don't let them get clots. Think about the INRs. Make sure you worry about, that's all you have to worry about. So come down here to inflammatory and infectious type stuff. That's all we're talking about. Infective endocarditis. We're talking about you have a microbial infection. It can be virus, bacterial. It can be fungi, whatever. Streptococcus. Man, these are the ones that really get you. And that's why I keep harping on them so much, because if you can understand that little concept, it makes all the bigger concepts just make better sense. So think about what infective endocarditis is and what it means. It's inflammation. It's coming to it. It's swelling. The heart is not going to do its job correctly. It's just not. Heart failure, it all leads to the same thing. So possible causes, oral cavities, skin rashes, infections, surgery. All of these things are things you have to worry about for your patient. It puts them at risk. I always highlight things that put your patient at risk because any test could say your patient is oral care, they have dental procedures, they have a skin rash, or they have some kind of a GI infection. All of those could lead to infective endocarditis, which could lead to development of a cardiac murmur. Because why? It goes straight to your valves. Your valve is the most likely place for that infective endocarditis to take place. You will hear new onsets of murmurs. It even says so here in your book. The documentation of new murmurs could be a sign of infective endocarditis. Changes in existing quality or intensity of a murmur could be infective endocarditis. I think about these things. Also, splinter hemorrhages, where your fingernails start to do this. Signs and symptoms of, once again, infective endocarditis. But when we start thinking about infective endocarditis, it's just going to be heart failure. If it's in the valves in the left side of the heart, it's going to look like left side of heart failure. If they're on the right side, it's going to look like a right side of heart failure. It should make sense at this point because there's valves all over the heart. Depending on which one gets screwed, that's how it presents. Heart failure is the most common complications is infective endocarditis. Why? Because cardiac output equals heart rate times stroke volume. And if those valves don't work, your stroke volume goes down. Period. It all looks the same. You won't even be able to differentiate. Heart failure looks like heart failure. Peripheral edema, weight gain, and anorexia is just right side of heart failure. None of these are specific to infective endocarditis. Left side of heart failure, fatigue, shortness of breath, crackles. I don't care what causes it. Left side of heart failure looks the same regardless of the cause. So how can you differentiate? How can you know? Little stuff like this, the little things, understanding why infective endocarditis works the way it does, understanding the murmurs, understanding that you never have to memorize anything anymore. You can be like, this kind of makes sense now. The petechiae, that's the splinter hemorrhages because it causes what so these are just things I want you to be aware of. These are some of the signs and symptoms that pop out where if I'm looking on an exam and it says splinter hemorrhages and petechiae and when it starts talking about infection and I'm like, oh, I ain't the smartest nurse in the world, but if you have an infection and you have some petechiae and splintering and you're having some shortness of breath and some dyspnea and some, what is that? Oh yeah, heart failure caused likely by what? Infective endocarditis. Let me start thinking about infection now. That's your job as a nurse. It's not the physician's job to tell you how to do your job. It's not the physician's job to tell you what's wrong with your patient. They've already told you what's wrong with your patient. They gave you a diagnosis of infective endocarditis. Everything else should make sense to you now. All of your treatment plans should make sense to you now. You don't need a doctor to tell you how to do your job because a doctor is not a nurse. A nurse is a nurse. Own that finally. That is how awesome you are. I don't need anybody to tell me how to do my job. I know how to do my job. So do you. So how do I do my job? If I have an infection, how do you treat an infection? You don't. You make sure the doctor ordered antibiotics. You need antimicrobials. You have to give IV antibiotics for 4 to 6 weeks to take care of this. Unfortunately, you know what other kind of patients are at risk for infective endocarditis? IV drug users. So a lot of these patients with infective endocarditis are also IV drug users, and they have to go to like an LTAC or a long-term care facility in order to get the antibiotics necessary to be better. Because you can't send a crackhead home with an IV. You can't. I don't mean a crackhead in a bad way because they smoke their stuff, but like, you know, somebody on meth or heroin or something like that. You get where I'm going. So these are concepts. These are ideas. These are what we're talking about. So we've gone through some of these. Pericarditis. This is another inflammation. It's inflammatory in itis. So the pericardial sac, the sac that surrounds the heart, has an inflammatory process. We're being specific. We're saying they all lead to heart failure. Heart failure is heart failure is heart failure. All heart failure looks the same. It looks just like this. What are the causes? Infection in your valves. What's that, ma'am? Oh, so infection in your valves is infective endocarditis. An infection in the sac that surrounds your heart that has the fluid that allows it to beat better is what acute pericarditis is. I don't know what causes it, nor do I care. It's not my job. If somebody tells me it's an infective organism, then they would prescribe an antibiotic and I would give that antibiotic. That's what I mean by that. Is not my job to determine what antibiotic to give. That's the doctor's job. My job is to understand there is an antibiotic, and if it's not the one I think it is, I should question the doctor. So knowing this, I know if you have pericarditis, I know that sac around your heart is inflamed. And I know if that sac is not movable and my heart can't do this 60 to 100 times a minute, my heart rate or my stroke volume or both are going to be diminished. Cardiac output equals heart rate times stroke volume. I'm in heart failure. It leads to the same thing. So it's going to look the same. What are the differences? That's what I'm trying to figure out for an exam. We already know it can be caused by infection. Great. It could be a myocardial infarction. Believe it or not, when your muscle dies, what happens? Macrophages come into the myocardial tissue. When you have a heart attack, your actual heart muscle dies. It doesn't just stay dead there. The macrophages come in, they eat that dead cells up and they get rid of it. And you poop it out later. That's why, you know, bilirubin is pooped out through your poop, and that's what gives your poop a brown color.
It's so ironic because yesterday we did a practice exam and
yeah.
they were going over rationales as to why you would see a WBC count over 14,000 usually.
Okay.
When it comes to heart attack, because what I know is that when there's dying tissue, white blood cells are going to come and eat it, like you say.
That's their job. Tie that back. Yes, absolutely. Thank you, sir. And tie that back into what we're talking about as well with pooping, and think about the liver, and think about how we can have clay-colored stools when we don't. You get all this stuff ties together. It's none of it is by itself. Your body is one unit. Everything impacts the other. So exactly it. When that muscle dies, the inflammatory process happens because white blood cells have to come eat that up. You will have fluid in the sac. You don't have to memorize everything. You have to understand the concepts. And I know y'all have heard that since day one in LVN school, 16,000 years ago. This is 265. This is where you're starting to understand it now. And I really want you to start embracing this. Quit trying to memorize crap and start trying to understand things, just like you're doing there. Now you're understanding, these are how things, you know how I learned this? I've read this book so many freaking times. I've seen so many patients. I've touched so many patients. I've had so many discussions and articles. It'll come to you. It's just not all going to come at once. And it's okay not to know it all. Do the best to understand the concepts. Everything else will fall in place. Do memorize a lot of crap for your exam. You have to, but know that there's becoming a nurse and there's passing an exam. Pass the exam. Do what you have to do that. But learn how to do your job so you love it and you can advocate for it and you can understand it, and you'll be a better nurse at what you do. So it's two-sided. Go ahead.
So about the fluid buildup, because I'm trying to understand. So
Okay.
in most cases, is it blood that's filling up in that sac, or is it just straw liquid?
Yeah, no, probably no blood at all. Honestly, this is another example of third spacing. When you start looking at everything, you understand peripheral edema, right? Y'all understand when there's right side of heart failure, the pressure in the veins gets so high that the fluid's got to go somewhere. So the fluid, the plasma starts to seep out of the vessels and get into the interstitial fluid. So if you were to look at my leg here, I got shorts on, it's okay. If I had venous problems, my leg would swell because the fluid goes somewhere. That's all we're talking about. Pulmonary edema is the same thing. The pressure in the venous, in the pulmonary vascular system is so high that it starts to third space, and all that fluid, plasma fluid, goes into the alveolar space. That's all acute pericarditis is. As the inflammatory process happens, it starts to build, that fluid's got to go somewhere, it seeps out. So it's typically that. If I stab you in the heart, and I would never do that, Mr. Rickson, but if I stabbed you in the heart, then you would bleed into the pericardial sac. So it could, or if you got in a car wreck and you hit your chest against the steering wheel and you rip one of the vessels, then it could be blood. It doesn't really matter what's in there, because what happens, ventricle squeezes, it re-expands, it depolarizes, right? QRS complex, T wave, QRS complex, T wave. As that fluid gets there, it compresses and it never comes back. So now you have zero cardiac output because the heart can't relax and repolarize.
And usually when you have fluid buildup in the pericarditis, and when you're doing your assessment, would you like hear muffled heart sounds?
Absolutely. And that's exactly what you have to be thinking about. You would hear muffled heart tones. So if you start going down here and listen, it says, here's another thing, pericardial friction rub. This is very much associated with pericarditis. So anytime I hear a friction rub, I go straight to pericarditis. I do. Where I listen to it at, it talks, it's really scratchy. You would hear muffled heart tones because you'd have fluid around it. You wouldn't be able to hear it as well. Absolutely. Down here as well, the ECG shows an ST elevation in all leads. Why? Because AFib is very common in this as well. It starts to cause a problem with the atrium. So acute pericarditis can cause AFib. It can cause clotting. It can cause these ST elevations. So right here, pericardial chest pain, presence of a pericardial rub, ST elevation, new or worsened pericardial effusion. There's all kinds of things associated with it. Ultimately, what's it lead to though? Heart failure. Because your cardiac output in your stroke volume is diminished. It's going to lead to everything else. Like, honestly, you're not going to really be able to tell soon enough. Initially, you'd be able to tell maybe right or left, I mean, whatever, but you're not, because they're still going to have problems breathing. They're still going to have issues with other stuff. So I always say, make sure you know this, make sure you understand that chronic constrictive pericarditis, that lasts more than 3 months, and it has signs and symptoms of right-sided heart failure. Pericarditis presents as right-sided heart failure. I'm trying to give you some insights. Everything looks like heart failure. I swear to God, every sign and symptom looks like heart failure. It does, because it all leads back to heart failure. If the left side of the heart fails, the right side eventually fails, right? If the right side fails, the left side eventually fails, unless we treat it. In this case, though, that will give you signs and symptoms of right-sided heart failure. So if you go all the way back up here to when Mr. Streb first said, understand the concept of, I'm just going to keep going back up until I get there. We can come back later. This is left ventricular failure. It's not saying, I'm saying this, these are the signs and symptoms that are associated with the left side of the heart failure. This is when the right side of the heart fails. If you know that, if you just internalize that concept and quit trying to apply meaning to it, right side of heart failure is not a thing. It is a group of signs and symptoms associated with anything that screws up the right side of the heart. In this case, if we're looking at, here we go, pericarditis, and we get down to, pericarditis. It looks like right-sided heart failure. So the signs and symptoms would be that systemic stuff, the jugular vein distension, the hepatic engorgement, because we know that the liver filters that deoxygenated blood before it returns back to the heart. So the right side starts to fail, it goes back into the liver and it starts to become engorged. Dependent edema, my legs will swell. Exertional dyspnea and fatigue. Oh, that was like left side of heart failure, because it all goes back eventually. If you can understand these concepts, it makes it way easier to get things right on an exam. It makes it even more easy to walk into your patient's room and say, based on these signs and symptoms, you might have pericarditis. Let me listen to your heart. Oh, it's muffled. Oh, there's a friction rub. Oh, let me call a doctor ASAP so we can do a pericardiocentesis, because I cannot do that. You have to be the one looking for these jugular vein distensions, these paradoxical pulses where they're uneven on both sides. You have to listen for those muffled heart sounds so you can call the doctor and say, we need a pericardiocentesis. That's what you're getting paid to do, because ultimately what happens when you get too much fluid in your pericardial sac, it causes a cardiac tamponade. Tamponade means you just stop the movement, basically, right? It happens when you get burns. If you got a burn in your arm and it burns your whole arm, it would get so much swelling, it would tamponade the artery and prevent blood flow down. That's what tamponade means. Tamponade means it's squeezing so hard that you can't get blood flow. Cardiac output equals heart rate times stroke volume. If I have no cardiac movement, I am going to die shortly. So you would hear maybe heart sounds. You might not feel pulses though, because if the heart can't squeeze, there's no cardiac output. That's what we're talking about. So the concepts all go together. I hope that makes sense on some levels. Oh no, I got to keep going though, because there's a lot of stuff here and I'd like to do more. I have all these chapters done, but I'm gonna at least get through this one because we're almost at 10 o'clock. Cardiomyopathy is a big concept you need to know as well. Know the signs and symptoms and the treatment for each type of cardiomyopathy. There are different types. As a matter of fact, there are 4, and Mr. Streb doesn't even remember all 4 of them. I'll be honest with you. I know there's dilated, there's hypertrophic, there's restrictive, and there's this one, arrhythmogenic, which is, do I know a lot about these? I'll be honest, I don't. I'm an ER guy. I work in the ER. I know a lot about the ER. Most of the time you come in with a heart failure, I don't care what your cause of heart failure is. I'm going to send you up to the ICU and then you can see a cardiologist later. So I'll be honest with you. Some of these things make sense. Some of them don't. But what I can tell you always is hypertrophic makes sense to me always. So let's talk about what cardiomyopathy is real quick. And it's just a disease of the cardiac muscle. It can become really big or it can become more dilated. And I'll show you what this looks like. They want you to really think about this. They want you to start understanding what it means when you have, a bad heart. It all leads to heart failure. So look at this one here. We talk about hypertrophy of the heart. We talk about the left side of the heart, the left ventricle. This left ventricle looks teeny tiny, right? There's no space in here. Your stroke volume is already diminished. Without going any further, I know that cardiac output equals heart rate times stroke volume. I can tell you with a hypertrophic cardiomyopathy, I have decreased cardiac output already because my stroke volume is garbage. I also have this great big muscle that is not going to do its job correctly, and I'm not going to get good cardiac output. Same thing on a dilated one over here. I don't have enough muscle to get good cardiac output. So either way, what we're worried about is cardiac output. It's always the same. It's either stroke volume or it's heart rate. Every single disease we talk about in this chapter and every chapter related to cardiac is going to impact cardiac output. It's the only reason we care. It's either going to affect the heart rate or it's going to impact the stroke volume. You decide. You can look at it. It could be both. So understanding that, we look at the cardinal features of hypertrophic cardiomyopathy. Asymmetric ventricular it means one side is bigger. The left side is bigger. It's stiff. You have left ventricle is stiff. It's not as receptive. You have decreased feeling. It's all about cardiac output. That's it. It looks the same. So what do we have to think about? We also think about restrictive cardiomyopathy. It's the rarest of forms, but I'm telling you, I don't get a lot into these, but they all lead to the same thing. They all lead to heart failure. So I think, I don't know what to tell you about a lot of this stuff other than when I think about what's going on with cardiomyopathy, reduced stroke volume, and cardiac output. That's all you really need to know. It leads to ventricular dysrhythmias as well. So you could have VFib, you could have pulseless VTach. And we know when you have VFib and pulseless VTach, you are dead. It doesn't get any worse than that. So we have to understand that cardiomyopathy, if the left ventricle, look at this left ventricle, that's going to be a VFib problem. Think about the SA node fires. It goes to the AV node. It goes down to the bundle of his. It goes to the left bundle branches and the right bundle branches, and it's going to cause these Purkinje fibers to squeeze. If we already have structural changes to the heart, we're going to have problems with electrical conduction systems. We're going to have excitability of the myocardial tissue here. You are going to have ectopic beats coming from the ventricle, and you might very well go into VFib or pulseless VTach. It should start making sense now. That's why we care, because you are dead. So if somebody goes in the VFib and VTach, we have to think about certain kind of drugs and calcium channel blockers and beta blockers and other stuff like that. So that's where we're at, y'all. That is what I wanted to talk to you about in this whole chapter. So I don't know how much time I put on the clock and what y'all got going. I can go to the next chapter if you'd like to. If you want to stop, you can leave, but I'm feeling pretty happy. So if you want to keep going to chapter 33, let me know.
Yes,
Yeah.
please.
Yeah. All right. Like I said, I can't reteach everything. Y'all know this. Y'all go to lecture, y'all read. My job is not to reteach. My job is to say, these are some big concepts that over the last 6 years of working at Galen with 242 and 265, these are the concepts I see people miss on the exams. When I go to the exam reviews and I see the concepts that people keep missing, when I look at the labs, these are the big concepts, y'all. So take what we're talking about today and go back and really use that information to help you just understand what you need to understand. All right, so let's look here at this one. Mr. Streb said the same thing. Go ahead and copy and paste right from the syllabus what you need to know about this. We are going to talk about aortic abdominal aneurysms, thoracic aneurysms, and a dissection of the aortic aneurysm. Before I ever start any further, we're talking about perfusion problems, so much so that we're talking about bleeding to death, basically, right? Most of the time, we don't bleed to death in America, we clot to death. This is one of those other sides where if you have a ruptured aneurysm, you will bleed, you will extinguish, and you'll be hypovolemic. So when I think about anything, I don't care about physician anything. I swear to God, y'all, I don't care about it at all. I care about the doctor to do the doctor's job. And I think about this from a nurse's perspective. What do I care about vascular problems? So as I scroll down and start thinking about what I know, perfusions and clotting, great. Inflammation, great. What are the nursing diagnoses that this is where I want you to start thinking. I, Mr. Streb, can do a lot of stuff about signs and symptoms and nursing diagnosis. Mr. Streb can't do anything for a medical diagnosis. You have to have medical treatments for medical diagnoses. Anyway, that's where we're going. I'm not going to get into hypertension because it's not part of our thing. Go back up here and look at what it says. It says we need to go right to page 7, 17, 18, and 19. I'm skipping all this. If you don't know hypertension, you better go learn hypertension. It is a good thing to know. So I am not going to work with any of that. I'm going to go straight down to aneurysm. And I know an aneurysm is what? What is an aneurysm to you all?
It is when the part of the valves stretch out that are dilate. I mean, the arteries, sorry.
Yeah, you're right. I got you. Artery. Absolutely. The artery, you know what I think about? If you've ever had a water hose outside at your house and you leave the water on too long and it gets this big old bubble on it, and you're like, oh, the water hose is screwed now. Because you know eventually that big old bubble is going to burst. That's all they're talking about. You have so much pressure, your hypertension, you did not control your blood pressure. Unfortunately, if you look at all of these diseases, almost all of them are caused by man-made stuff, which is stupid on our part. But if we go back and look at an aneurysm, we have this weakened vessel wall that unfortunately, if we don't control that blood pressure, has the potential to burst and sanguinate. So there are different, and I never even considered this. I have heard these words back in nursing school, but a true aneurysm means you have a weakened congenital acquired problem with the actual wall of the vessel. A false aneurysm means you had a vessel injury or a trauma years ago. Like one is something to all three layers. It's more, I don't know what you'd call that. They don't make a difference to me. I just thought it was interesting. A dissecting aneurysm is one where we worry about because it says they are formed when blood accumulates in the wall of the artery. And as that blood starts to accumulate in the wall of that artery, it starts to dissect and burst. So we'll get in there in a minute. I would just want you to get an idea of what an aneurysm is and how they can be problematic and why they're problematic. So as nurses, do we really do anything for an aneurysm? The answer is no. You and I are not ever going to fix an aneurysm. But what we can do is identify when there is an aneurysm in a location so we can call somebody far more skilled to fix that. That is my job as a nurse. My job is to do no harm. I am smart. I am educated. The law, the board of nursing who gave me my license says, I expect this of you. And the minute I don't meet the expectations of the board of nursing, they will take my license back from me and say, you are no longer safe to be a nurse. So literally, I am charged with knowing this information. I need to know that a AAA is typically asymptomatic and frequently ruptures. And that's when you typically find out you had a AAA because you died, right? Because you don't even know. A thoracic aortic aneurysm, not near as common. It's kind of in that same area. It's location-wise. I'll show you in just a minute. So what are we worried about? We're worried about a ruptured aneurysm because when it ruptures, you can go into hypovolemic shock, hemorrhagic shock, whatever you want to call that. It's massive loss of blood volume. And if I don't have blood volume, I don't have stroke volume, I go into heart failure, I die. It's all the same thing. It leads back to the same thing. I swear to you, it all leads back to heart failure. So that's why we care. So atherosclerosis is a common cause. We know that as it starts to hardening, your hypertension, your hyperlipidemia, you smoke too much. You're welcome. You killed yourself. Like all of this stuff is our fault. So we have to think about all of that preventative stuff. That's why everything matters when we're talking about a patient before they get to this point. We need to talk about what hypertension and hyperlipidemia and all that can lead to atherosclerosis, which in turn leads to aortic aneurysms and thoracic. All of that matters. That's a care plan. That is a concept map. That is what you should be doing at 265 and until the day you graduate, and then keep doing it. So what do we need to worry about? You need to know about the signs and symptoms. Pain is usually described as a steady, gnawing quality, unaffected by movement and lasting for hours and days. Those are some of the things you might hear for a AAA. Maybe not. A lot of times there's just no pain at all. They don't feel anything. You might see a pulsation. I made that in green because if you see a pulsation between the xiphoid process and the belly button hole, that could be a sign and symptom of a aneurysm. Why would you seeing a pulse might make you believe there's a AAA? Why? Why shouldn't you see that pulse initially?
If it's bounding. If it's bounding.
It could be bounding. It could be bounding. Go back and look at this. If I'm laying flat and this is my regular artery, you shouldn't see anything. If this is my artery and it's swollen and big, is it not closer to the surface of the skin? You're literally going to have an artery closer to the surface of the skin where you can actually see the pulsating. You wouldn't typically see it in the aortic, abdominal aorta because it's so far under the skin. But as it starts to swell and as it starts to grow, it actually comes closer to the surface. That's why you might see pulsation between the umbilicus and the xiphoid process. That should make sense now, right? Knowing that lets you detect things. You won't notice it until it's big enough, but then you can auscultate, just like when you have a bruit, right? When you have an AV fistula for somebody who is on hemodialysis, which I know you're talking about now, you still auscultate for that bruit because you're going to hear it because you're going to have this turbulent blood flow in this great big expanded aneurysm. That's what we're talking about. The signs and symptoms should make sense. You shouldn't have to memorize this at this point. You understand how blood flow works. You understand how big blood flow in one area is going to be louder. It makes sense. Now, when you start thinking about thoracic aortic aneurysm, it's typically back pain, shortness of breath, hoarseness, difficulty swallowing. Why? Because thoracic, we're talking about the artery up here in your chest now, right? We're not talking about the one in your stomach anymore. It makes sense. The signs and symptoms should be more in this area. That's all I'm trying to get you to understand. You don't have to go back and know everything about AAAs and all of this. You need to know what they sound like, signs and symptoms. What Mr. Strip it over here? Know the signs and symptoms. I'll put it somewhere. Know the signs and symptoms. Understand that. Understand what it looks like. Understand what you're trying to prevent and what your job is in all of this. So if you have a ruptured aneurysm, AAA or a TA, all you can do is go to surgery. If they can fix it, great. If not, you're going to bleed to death and die. There's not much more you can do. That's what an aortic dissection is. So you can have a AAA, you can have a TA. Those things are great. If they don't rip or they don't tear, if they don't, nothing else, you'll be fine. An aortic dissection means just that. You have a dissecting aneurysm. You are going to have you're going to bleed. And depends on how much it dissects and how much you bleed. It depends on the lethality of it. So very highly lethal. It's an emergency situation. You might not make it. Common symptoms right here, pain description. They'll say, I'm having a sharp pain, a tearing pain, a ripping pain, a stabbing pain in my stomach. If somebody says that, you don't be like, okay, what is the quality of your pain? Well, on a scale, like, I don't care anymore. If you tell me that and I can see a pulsation, I'm calling rapid response right now. I'm calling a code. I'm not even doing rapid response. I'm getting everybody down so we can take you to surgery immediately because you're not going to live if I don't do something. So there's all kinds of stuff you're responsible for, but that's it. That's that whole chapter, y'all. I'm not going over anything else in that chapter because your syllabus said I didn't have to. Are there any questions on that that really kind of pop out that scare you or concern you? All right, then I will keep moving on. That was a quick chapter, so I'm just going to go to 34. If y'all are still with me, is 34 a chapter? Yeah, we go to 35 next, right? What'd you say, sir?
Yeah, I was saying that cardiac has been like my weakest in all of nursing school. But
good. You stay here with me. Look, I have nothing better to do on a Saturday right now. Literally, I mean, I could do a lot of other stuff, but I'm having a good time, y'all. So if you're happy and want to stay, I am happy to stay with you. And I will post this long old session later on. So, all right, so let's get to the last part. The last part is chapter 35. Your syllabus says we need to know about acute coronary syndrome, which y'all, it's the whole freaking chapter. Acute coronary syndrome it's just a big concept to me. It includes myocardial infarction. It includes the need for hemodynamic monitoring, like when you put in a Swan catheter or a triple lumen and we get the ICU. Cardiac surgery. We're going to talk about those few things. So I have highlights in here already. When I think about acute coronary syndrome, what I want you all to do is think about it. We're talking about perfusion and pain. The book tells you what the important stuff is: perfusion and pain. Just like in the last chapter, when it talked about aneurysms, it talked about perfusion and clotting, because there are things that, this is what we're going to focus on. We're going to focus on perfusion and we're going to focus on some of the pain related to it, because we're talking about a decreased perfusion, because myocardial infarction means we don't have enough infusion into our myocardial tissue. Acute coronary syndrome. So what does coronary mean? Let me ask you that right off the bat. What is coronary? What does that refer to?
The vessels and arteries.
Yeah, we're talking about the heart, basically. That's what I think about when I think of the word coronary artery disease. We're talking about the arteries of the heart. That's it. If you don't remember how the body works, I'm going to say it one more time. The right atrium receives blood that is deoxygenated from the body via the superior inferior vena cava. It dumps into the right atrium. It goes through that tricuspid valve into the right ventricle. The right ventricle shoots that through the the pulmonic valve into the pulmonic artery into the lungs. The lungs, we get gas exchange, O2, CO2. It comes back into the left atrium through that mitral valve into the left ventricle, where it shot out the aortic valve to systemic circulation. When it goes to systemic circulation, it goes right back into the coronary arteries, because coronary arteries provide blood to the actual myocardial tissue. So just because there's blood inside the chamber, it does not give you oxygen. It has to go back through there. So when we have coronary artery disease, y'all, that's all a heart attack is. That's all myocardial infarction is. It is when you have a blocked coronary artery and you can no longer get blood flow to the myocardial tissue. The myocardial tissue infarcts, it dies. That's what a heart attack is. Same, no difference. So understanding coronary artery disease lets you know if I have diseases of my coronary arteries, I'm going to have problems with blood flow. Once again, perfusion to my myocardial tissue. If I don't get blood flow to my myocardial tissue, what happens? It hurts like hell. I have pain. This is not a hard concept. If you just follow the book every single time, it tells you exactly what you need to know and how it works. So let's get right into it. Acute coronary syndrome. What does that even mean? It means that your coronary arteries are jacked up. That's what it means to Mr. Streb. And if I'm not getting good blood flow to my muscle, it's going to hurt. We call that angina. Your book is very specific on the different types of angina. There's unstable angina and there is stable angina. If I know I have clogged arteries in my heart, I know if I go dancing, if I have sex, if I go run, I increase the workload of my heart, I increase the oxygen demands to my heart, it is going to hurt. That is stable angina. Unstable angina means I'm sitting on my couch doing absolutely nothing, and all of a sudden I feel like Sanford and Son. It's the big one. I feel like I'm going to die. There's no reason you should be sitting on your couch ever and feel like you're going to have a heart attack. That's what unstable angina is. It means that instead of having this cute little pretty lumen in your coronary arteries, you now have clogged it up with fat and cholesterol, and maybe you had a burst something and you have a hematoma there, a thrombus, whatever. There is no blood flow anymore. If I have to go run or walk or do anything, climb a flight of stairs, go take a poop, whatever, I'm increasing the workload of my heart, there's not enough oxygen getting through to make my muscle not hurt. That would be stable angina. Unstable angina is you didn't know you had any of this and you're sitting on the couch, a total blockage. So I need you to be able to understand what the difference is between stable and unstable. Unstable is pain that occurs at rest, doing nothing. Why? Because it's ischemic. Your muscle is ischemic. Ischemia means you're not getting oxygen and it's going to die. That's what we're talking about. Acute coronary syndrome, we're talking about unstable angina. Unstable angina is a clogged artery that is preventing blood flow to your myocardial tissue. It is a precursor to a myocardial infarction because it says ischemia is present in unstable angina, but not severe enough to be detectable by myocardial death. We call that troponins. So yes, you are actively having a heart attack. I swear to you, you are. We just can't pick it up yet. Your troponin levels aren't high enough yet. What are troponins? Troponins are chemicals released by your myocardial tissue when it starts to infarct. So if somebody has unstable angina, it is a medical emergency. It is going to lead to a myocardial infarction eventually, maybe not right this second, but it will. So myocardial infarctions are just that. The myocardial tissue dies because it doesn't have any blood flow to it. And what's that mean? Ischemia. Look what it talks about here. There are two types of ischemia. There is a non-ST segment elevated myocardial infarction. We call that an NSTEMI. And there's an ST elevated myocardial infarction called a STEMI. They're both heart attacks. One is a complete block, one is not a complete block. That's what we're talking about for the most part. We'll look at more of that, and I've also covered it in previous lecture if you need to go back and watch it. But do yourself just understand that a STEMI only means that I can see it on an ECG machine. That is it. Whatever happened. It shows up on an ECG differently because I have ST, either depression or I have ST elevation. Non-ST elevated myocardial infarction. It means your ST segment on your ECG did not get elevated when you had a heart attack. This says your ST elevation did occur after you had a heart attack, and I can see it. What am I talking about? A STEMI just means that a thrombus caused an abrupt 100% occlusion to the coronary artery. If you have a 100% blockage in your coronary artery, you will 100% have a myocardial infarction of that part of the heart that does not have blood flow. 100%, I guarantee it. You know why? Because you have to have oxygen. I know this. That's what we're talking about. That is a true medical emergency. You have to go and have surgery. You have to go in and they have to give you a thrombolytic agent to bust it up, or they have to go in there and put a stent or remove it or something.
Question with that. When do you use a cardiac catheter in this case for the plaque in the arteries?
You can do both, and that's not my concern. That is the physician's concern. We'll get there in a second, but you can do it on either one. If there is a blockage and that doctor wants to do it, that doctor will do whatever that doctor wants to do. And that's why I say it this way, y'all. I can't think about nursing on, the doctor can do it for both. And if you get down here and read, it even talks about it. I even highlighted it for you where it talks about, I'll find it in a second. The treatment is both. You can do it for both. Initially, it would all depend, and I'll show you that in a moment when I find it. But it's a great question. When your patient comes in, the physician is going to decide. So when I have somebody coming for a STEMI, I usually do a code STEMI. So in most hospitals, we'll do a code STEMI, meaning I have a 100% occlusion of this coronary artery. And if somebody does not come in here and unblock it, the myocardial tissue will keep dying. Do I always do that with an NSTEMI? The answer is no, because an NSTEMI indicates the myocardial ischemia. Initially, the troponins are low because it's not 100% blockage. We might have time. They might be able to do some kind of clot buster. You have a little more time, but when you walk in with 100% blockage, the only thing we're going to do is take you back there for surgery. Somebody else is going to unblock that. Does that make any sense, Mr. Rickson?
Yes, yes, sir.
Yeah, you have time on the in-STEMI. You don't have no time on the STEMI. So I think that's really what's going to drive the train. The physician's going to feel, they're going to look for cardiac death. They're going to look for troponins. When you come in with this 100% blockage, your troponin is going to be elevated. Your serial troponins, I'm going to draw one now, and 4 hours later, I'm going to draw it again, and 4 hours later, it's going to steadily keep going up, showing that you're having an active heart attack. That's why we do the difference. Great question, though.
So to understand this, sir, so unstable angina can lead to MI.
Unstable angina will lead to an MI. Unstable angina says you have a clogged coronary artery, but it's not completely clogged yet. So if I were looking at unstable angina, in my mind, and this don't take this as 100%, but this is how I correlate things in my mind only. If I'm thinking unstable angina, it's a lot like an in-STEMI. I do have ischemia to my muscle. I swear to you, when you have unstable angina, the book says you have ischemia present. Ischemia is death of that muscle. It's just not enough death. That's all unstable angina is. It is another word for saying you are having a freaking heart attack. It's an in-STEMI. That is what it means to me. If any other teacher tells you different, that's fine. That's their opinion. But to me, it's the same freaking thing. If I'm sitting there saying, oh shit, my heart hurts, excuse my language, it hurts. It's because it's ischemic. That's an in-STEMI. I don't have enough to raise my troponins yet, but wait long enough and you will get more and more cardiac death. That's the only difference. A STEMI is saying I have 100% blockage. I'm 100% having an MI right now, and I need to do something about it right now. You will have an MI. You are having an MI.
Okay.
You are having an MI on both. We just don't say that. If you have unstable angina, you are having a myocardial infarction. I don't care what anybody else says. Why else would your muscle be hurting? It's ischemic. It's dying. So I get excited. It's not you, Rickson. I just get excited when I teach.
One last thing. So for stable angina, is like you are like when you have stable angina, can you like climb 2 flights of stairs?
Yeah, stable angina means you have a clogged artery. You know you have a clogged artery. It's not clogged enough where it's causing ischemia, because if it's causing ischemia, nobody would let you go home with an ischemic heart muscle and say, oh, well, it's stable, just go die. They wouldn't. They say you have stable angina because you have zero ischemia. But understand you have a clogged artery. When your butt needs to walk up the stairs and you increase the workload of the heart, it is going to try to pump more blood through that little bitty artery that clogged, and it's going to hurt. Because as you start becoming more active, you are causing ischemia. That's what angina is. Stable angina says you will not have ischemic heart muscle if you don't overwork your heart. But the second you start doing more than you should, that chest pain, oh yeah, that's your heart muscle dying. That's exactly what that is. That's ischemia to the myocardial tissue. On some level, that lack of oxygen is killing myocardial tissue. So if I had angina, I would do a lot to fix that right away. I'm serious. I don't know what I would do, but I would not eat a certain way. I would exercise more. I'm just letting you know. All of those are precursors to you dying of a heart attack eventually, because you have a blockage of a coronary artery. And the minute that blockage becomes problematic, it's unstable. And when it becomes more and more unproblematic or problematic, and now it's a STEMI because now it's 100% blocked. And now I know you're screwed. So when you come into my ER, you're screwed, not near as screwed as this. This is worse. This is worser. These are the words I use. This is how Mr. Streb literally looks at patients when they walk into his ER, because it makes sense to me. I don't care if it sounds smart or politically correct. I understand this material based on the way I understand it. I don't care how you guys understand it. If you understand it based on, that's all you got to do. So does that help, Mr. Rickson?
Yes, it sure does. Thank you.
Cool. Yeah. I know there's a lot smarter instructors out here and their lectures sound way more professionally, but I don't care. This is how I learn material. And if it works for you, great. If not, Nancy McConnell's a great person too. She can probably give you better information than I can, right? Not you, Mr. Rickson, but yeah, learn from multiple people. I will say something in a way that makes sense. Miss Nancy will say it in a way that makes sense. Your coworkers, your other teacher, listen to all of us say the same thing. And then you decide. A lot like religion. People's got opinions about a lot of stuff. You decide what makes sense to you and live your truth, okay? You'll be a much better nurse. The last thing I want to say about that is catecholamines. Do y'all remember what catecholamines are? You might not, They're epinephrine and norepinephrine. What happens in response to hypoxia? What happens with pain? We increase our heart rate, contractility, and afterload. Why? Because if I'm hypoxic, I'm not getting enough oxygen to my body. What does my body automatically do? It compensates. So when I'm having a freaking heart attack, my body says, oh, we don't have enough oxygen. Make the heart beat faster. Make the heart work harder. No, y'all, I'm having cardiac death. If I have a STEMI and I'm having pain down here because there's no blood flow, my brain says, oops, I need you, kidney, to release more epi and norepi, because we need more blood pumping through this heart to go down this artery to get more oxygen down here. It's not going to happen. You have a blockage right here. I don't care how much the heart works. Now, if the heart works faster, it's causing more and more tissue death. So what is one of your priority interventions when it comes to myocardial infarction? Is to decrease the workload of the freaking heart. You have to stop the heart beating so fast. You have to stop the contractility. You have to decrease afterload. If not, you're increasing the oxygen demands and you're further causing more tissue death. So what do we do anytime somebody has a heart attack? We do MONA. What is MONA? Morphine, oxygen, nitroglycerin, and aspirin. What does morphine do? Morphine just decreases the workload of the heart. That is it. Morphine causes vasodilation. I didn't spell that wrong. To counteract the epi being released by the body in response to hypoxia. If we don't give morphine, we allow the heart attack to make the heart attack worse. We need vasodilation. We don't give morphine for pain. We give nitroglycerin for the same reason, vasodilation. That's why we give morphine. Also, because if we can decrease pain, it also decreases all kinds of stuff. But we don't give morphine for pain just because you're hurting. We give morphine to decrease the workload of the heart. Everything we do as nurses has a reason. I decrease the workload of the heart so I can decrease the demand of oxygen and I can decrease tissue death. That's why we do anything. It's not just because we're making stuff up. There's a reason. So that's where you're at with myocardial infarction. Go back and think of diet. I've seen on ATI and NCLEX, I don't know about your exam, but I know that diet always talks about knowing sodium. Know how much sodium. Physical activity talks about exercise. Know that it's moderate 3 to 4 times each week. Like I've seen those on ATIs and NCLEX. I don't know what you're going to see in the future. I'm trying to help you become a better nurse, not pass just this one test, but I'm also trying to help you pass this test. So that's where we're at. Laboratory findings. What tests do we look for? Troponins are the gold standard for an MI. They're not the only test, but they're the most common because we know troponin 1. Troponins are specific to the myocardial infarction because when myocardial tissue dies, it specifically releases troponins. And as troponins increase, I know the myocardial tissue died. That's why we do troponins. That's why we do serial troponins. Because if you're having a heart attack at 3 o'clock, at 7 o'clock, if your troponins are getting worse, still tissue death. At 1 o'clock, if they've gone down, oh, we've resolved the problem. Now your tissue death is no longer happening. That's how we know that after you go and do a cardiac catheter, or once we give you TPA or something, when the troponins start to go down, I can look at it and say, oh, cause and effect. No different than when I send you to dialysis and I bring you back and I check your potassium levels. If your potassium levels are going down, I can say, oh, dialysis worked. If I give you medication and your troponins go down, we can say, oh, it worked. That's what we're looking at. So make sure you understand troponins are the gold standard for MI. Understand that BMP, that brain that peptide, that's for heart failure. They're different. And MI will lead to heart failure because if your muscle can't squeeze, you don't have cardiac output, plain and simple. Heart failure is not a disease. Heart failure is what happens when your heart doesn't work. That's it. So I put a couple more things in here. The purpose of interprofessional collaboration care is to decrease pain, to decrease myocardial demand, oxygen demand, to increase perfusion. Everything that we're going to do is going to decrease pain, increase perfusion, and decrease oxygen demand. Everything we do is scored towards that. Morphine sulfate decreases myocardial oxygen demand. It relaxes smooth muscle. It reduces the circulating epinephrine and norepinephrine so it doesn't make the heart work harder. Somebody way smarter than you and I figured this out. I don't need to figure it out again. I just need to know why. So we do that. It starts making sense. My point to you, I know this is your first test coming up in what, another week? if you do this, if you go through and read, if you listen, if you pre-read before you go to your lecture, and then you go to your lecture and you listen with the intent of understanding what the concepts are and what your purpose is, and then you come and attend some of these or listen to these, we'll just re-strengthen what it is. You'll hear it 4 or 5 times. It starts making sense on how the body works, and you never have to guess anymore. I hated nursing school sometimes, and I hated teaching when I first started because I didn't know enough. I had to go back and read it. I had to understand it. Once I understood, I was like, well, this doesn't make any, this is so simple. I started reading with intent of learning and not just trying to pass a test. So in nursing school, you're not always going to be able to do that. I get it. Do your best, accept what you don't know, and move on. If you get to a test question, you don't know it, just move on. You're going to miss a lot. It's okay. So here's the question you asked earlier, Mr. Rickson. When we think about therapy to bust up clots and stuff, right? Thrombolytic therapy. That's what I called it back in the day. Now we're calling it this, right? I get it. We're talking about fibrogen, still a clot. Thrombolytic, still a clot. Whatever makes you happy. We're talking about a buildup of something that's blocking blood flow to the myocardial tissue. So we can either give you something to dissolve the thrombi in the coronary artery to restore that blood flow, which is great. So we can give you TPA, retin-place, any of these. These are things to just know. The doctor will do that, but they do. The PCI is a treatment of choice for what? PCI is what? You're like, what is PCI? I'm going to talk about, I don't think it's up here. PCI just means cardiac catheterization or something like that. You can go back and read what it talks about. But for a STEMI, we want to remove the clot right away. What did I just do? I'm sorry, y'all. I don't know where I was at. We want to remove the clot right away. Why? Because it's 100% blocked. So we're going to do that. We're going to go in there and remove it. PCI. Go back and read what that is, but this basically means we're going to go in there and remove the clot. Otherwise, they can do that. And here's what the PCI indicates for a STEMI should be considered for blah, blah, blah. The goal is to administer this therapy within 30 minutes. So these are things I want you to understand. Patients who cannot receive PCI, they need to be started on one of these. When you walk into the hospital, we have a 30-minute window to start that. It's a lot like a stroke, y'all. A stroke and a heart attack and a PE are damn near the same thing. You have a blockage of blood flow to your brain, that's going to kill you. That's a stroke. You have a blockage of blood flow to your heart, that's going to kill you. That's a stroke of your heart, or it's a heart attack of your brain. It's the same thing. It's a clotting problem. It's a blood flow problem. That organ will die if we don't do something. So 30 minutes, that is always your gold standard. I've seen that on so many different places. That PCI or that need to do percutaneous coronary intervention. They're going to go in through your artery and they're going to fix something. That is your STEMI, because there's nothing more we have to do something. But that doesn't mean that they can't do it for an NSTEMI if they decide. They probably will try something least invasive first, because if I stick something into your heart, I also risk the chance of causing an arrhythmia and you dying. So least invasive to most invasive. Here are some other things. Absolute, relative. These are some contraindications for thrombolytic therapy. You will never take thrombolytic therapy. So we're saying TPA versus a catheter, basically. Sometimes you can't get TPA because you got other stuff. So the doctor might say, oh, I would like to do TPA, but based on what you got going on, your bleeding disorders, you're on your period, I'm not giving you TPA. Now we're going to go in and do a PCI. So that's what I'm talking about. If your patient has an intracranial bleed, they're never going to give TPA. They're going to go in and do the PCI or the catheter. If you have this or this or this, if you are actively bleeding or you're on some kind of bleeding diatheses, that just means bleeding abnormalities. If you have a known clotting disorder, they're not going to give you TPA. They're going to go in there and put a stent in. So Mr. Rickson, if that answers your question, it depends on the patient. So I don't ever just answer anything first. I say it always depends on what's going on with the patient.
Okay,
so,
thank you.
Yeah. So you can go back and read this. This is the PCI part. What are they going to do? They're going to put this STEMI. They're going to go in through one of your arteries. It could be your femoral artery. It could be your radial artery, whatever they want to do. They're going to go in. They're going to find the clot. They're going to put a balloon catheter through there, and they're going to inflate that catheter, just like my mom when they did her TAVR, when they replaced her valve in her heart. It's the same concept. They go in with this small wire. They inflate a balloon. It pushes the scarred tissue. It pushes the broken valve. In this case, it pushes the plaque formation to the side. And that balloon opens up the artery. Then they might come back in there, or they might not. They might come in there with a stent where the same balloon comes in. It's got a metal fat flashing around it. They inflate the balloon. It opens up that metal structure, and now that structure is your stent. Same. All you're doing is trying to make this occluded coronary artery right here, blood flow. I get all the ischemia down here because I have a clot. Once I open it up, there's no more ischemia. So this could be unstable angina. where I am getting ischemia down here. And they're like, screw it, let's go in there and put a stent. And then they do the stent. And now I have returning blood flow. Yeah. So there you go. That's really what our jobs are there. So what do we have to think about? We're going to have to think about managing that left ventricular failure. Y'all already know what left-sided heart failure looks like, because why is left-sided heart failure the most important? Because if the left side is not pumping blood to meet the demands of the body, we all die. Right-sided heart failure kind of sucks. We get a little swollen, but it doesn't kill us initially. So we think about managing left ventricular failure. How do we do that? This is definitely a 265 part that is way different than 242. 265 is ICU, y'all. 242 or 170, whatever you had at your campus. 242 is what we do in San Antonio. 170 is what you do in other spots. Maybe, I don't know. But 265 is what we're in now. And these are all critical patients. These are all ICU patients. That's what 265 is. These are not med-surg patients where you can look at them and try to figure out what's going on. No. You're in the ICU with a patient who's going to die if you don't know your job. So as you're reading this, read with the intent of knowing I have 2 patients and I'm responsible for every single thing about this dude. So if you are responsible for somebody who's critical, who could die at any moment, I promise you in the ICU, we put you on hemodynamic monitoring. All this really means is that we're going to take a catheter and we're going to insert it into your freaking heart so we can actually monitor your temperature inside your heart. We can look at your arterial blood flow. We can start looking at everything real time, what your heart is doing. I don't want to check your pulse at your elbow. I don't want to check your pulse at your foot. Great, that's systemic circulation. I'm looking at central circulation monitoring. That's what hemodynamic monitoring is, because these patients need us to know everything about them, because if we don't, they could die. I'm not going to get into all of this. You have to read on your own, but I want to tell you what that looks like. We will take like a swan catheter, a triple lumen catheter, and we will go in to the superior vena cava, right through your subclavian vein, and we'll go into your heart, through your right atrium, through your right ventricle, out your pulmonic valve right here, into the vasculature system of the pulmonary system. We call this a wedge pressure because we literally wedge this catheter into this small arteries there. That's all we're doing. It talks about it somewhere in here, wedge pressure, because the balloon is wedged into the small vessels. It's called POP. That's another word that I call it a POP. You might hear that people say, oh, what is your POP or your POP or whatever. These are just different words. I'm talking about a wedge pressure. How much pressure? The normal wedge pressure is 5 to 12. Why does that matter? It doesn't, because you're not in the ICU yet, but I've seen those on types of test questions. Why did we put that in there? Because we're trying to measure your left ventricle failure. We're looking at hypervolemia. We're looking at mitral regurgitation. We're looking at certain things. So we know that when you have an elevated POP, that's what it looks like. You know, when the POP is decreased, we have hypovolemia. We have afterload reduction. These help us figure out what's going on with the heart. So you're in 265 now. You have to know this stuff. I can't tell you any more than that. Like, just understand. Part of your job now might be, oh, your patient has an elevated POP. What do you expect? Or what would your next heart failure? You would expect heart failure. You would expect fluid volume overload. You would expect wet lung sounds, all that kind of stuff. So I can't possibly tell you everything because I don't know what we're going to choose for test questions this term. I don't know what ATI is going to choose, or NCLEX, or 280 or 283. But what I can get you to do is learn how to use this book in a way that will help you on every exam you ever go into. That's what I want you to do. What else can we do? Coronary artery bypass is pretty much before heart transplant. If you have a clogged artery and they can't do anything to fix that, my mother had a double bypass surgery. When she was 30 something and I was like 16 or 17, she had breast cancer. She had a mastectomy. She also had radiation and chemotherapy. Radiation and chemotherapy saved her life. She died when she was 74. So she lived another 40 years. She didn't die of that. She died of heart disease. Guess what? Radiation caused her mitral valve and her other valves to become stenotic. They also caused her coronary arteries to become stenotic, meaning they're hard. They would no longer dilate and contract. So she didn't have good blood flow. She lived, but this killed her also. So they went in and did a bypass graft. And as a matter of fact, Mr. Strap got to go into the OR and watch my mother have open heart surgery, which was the stupidest thing that the doctor could have ever let me do. I didn't pass out, but I almost did it first because she was covered up. I didn't see her face, but I got to watch my mother's chest be cracked open. I didn't watch that part. She was already cracked open. I watched her on a machine where her heart wasn't beating. That was so cool and weird at the same time. What did they do? A coronary artery bypass graft means they have a blockage. I'm gonna go back to this picture up here. I'm gonna keep going back up just for a minute. Hold on. So you have, oh my Lord, you have a blockage. If you have a blockage right here, they will go into your leg and they will harvest something called your great saphenous vein out of your leg. They will attach it right here. They will bypass the blockage and they will restore blood flow around that blockage or that stenotic or damaged vessel. That would be a one-time. If they did this artery and this artery, you would have a double bypass. If you did this one, and this one, you'd do a triple bypass. You would do a quadruple bypass. Coronary artery bypass graft. You're grafting a vessel on here to bypass the coronary artery. That's what CABG is. So a CABG is a blockage that you bypass. And they typically do it by harvesting like a great saphenous vein out of your leg, and they use that to bypass it. So for traditional surgery, that's what they do. I just told you that. They'll take the leg, they'll do whatever, but they put you on bypass. So they will connect your freaking heart to this machine that pumps the blood, filters the blood, returns it back to your body and sends it back. It is so crazy. The heart doesn't beat during the surgery because they're in there cutting and doing stuff. Y'all is blown away by it. And then to be your mom, even crazier. So what do we have to worry about? I don't know. I'm just letting you know. This is something I do know. As the blood leaves the body and it goes into that machine, it is heparinized because it has to be heparinized. Otherwise it will clot. And when it comes back to the body, you have heparin in your body. So now you are more at risk for bleeding. You also, just like dialysis, it heats the blood up. So when it comes back into your body, you might have increased body temperature. Just like somebody after hemodialysis, it's not unlikely for them to have increased body temperature because you heated the blood. Things just have to start making sense to you. All of these perfusion issues go together. So that's CABG, y'all. I don't know. This is CABG. This is a way better thing than I showed you. This is a big old CABG where they started way up here and they bypassed the whole freaking thing. And so we're going all the way down. Here, 1, 2, this is a triple bypass surgery. And that's what they do with my mother. That's what they do with anybody. These are caused sometimes by your diet and exercise. Sometimes they're caused by your smoking. In my mother's case, it was caused by breast cancer. Not really. It was caused by the radiation to treat the breast cancer. So just let people know. No, do your best. No, you're not going to learn everything. No, it is impossible for any of you to get in this book and learn everything we just talked about. It is impossible for you to go back there and be the expert at any of this. Learn the concepts, because what we're going to test you on is your ability to look at a patient and figure out how not to let them die. Figure out, based on what these signs and symptoms are, I need to take these actions to decrease the workload of the heart and restore blood flow to this vital organ. When you can do that, you'll get every question right. I know this to be a fact because I met with a girl yesterday. She's not even my student anymore. She's one from a previous couple of years ago, and she's, I don't know, a couple of semesters ago, and she's taking a test. I went over stuff with her, just questions and answers. Out of 60 questions, I got one wrong because that's not the way it was written. I don't need a book to tell you what the answer is. You know how I know this? Because I can only do what a nurse does for nursing diagnoses. Literally do concept maps, understand what happens to a patient when they have these diseases, and understand what a nurse can do to help, because every test question will do just that. All right, that's all I got. I'm going to stop recording, y'all, but I'll be more than happy to talk